afternoon. We are at the Diabetes Spanish Society annual meeting here in Granada, and we are talking with Professor Colin Dayan. Professor Dayan is a professor at the University of Cardiff from UK. Thank you for being here with us. Professor Dayan is going to give us today the opening ceremony, the opening conference regarding prevention of type 1 diabetes. Thank you for coming to Granada. Thank you for coming to our meeting. We would like to know what are the more important ideas or thoughts that you are going to tell us this afternoon about prevention of type 1 diabetes.
Yes, thank you, Luis, and it's a pleasure to be here in Granada, really great pleasure. So I think this is a very important time in type 1 diabetes where we're changing our emphasis. So for over 100 years, type 1 diabetes has been insulin. That's all we think about, giving insulin. But we've forgotten that this is not an insulin disease, it's an autoimmune disease, it's an immune disease. And so the idea is that if we can treat it with immune therapy, maybe we don't need insulin. So that's what we mean by prevention. The idea is to treat it early in order to never need or to delay the need for insulin.
Yeah, and are we ready? Do we have drugs already to treat this, to prevent diabetes?
Well, we need two things, not just the drugs. We need to be able to find the people to treat, because before they need insulin, they're not sick, so they don't go and see a doctor. So you have to find a way of detecting people in an early stage. Now there's been a lot of work on that in the last 20 years, and we're pretty good at doing that with a simple blood test for antibodies to the pancreas, to the islets of the pancreas. We can detect people who have a 90% chance of needing insulin in the coming years. So that bit we're in good position on. In terms of the drugs, we have more and more. There's only one that is licensed, and it's not licensed in Europe, it's licensed in the USA in November 2022, and that's teplizumab. So that's the first drug, and a 14-day course of that drug prevents the need for insulin by about 2.5 years. So there's a longer delay before you need the insulin. But there's at least another 9 drugs that have shown promise in this direction.
Okay, and I hear that several countries all over Europe, they are moving for screening to look for these childs or patients that will develop clinical diabetes. That means they have in the early phases of type 1 diabetes. How are you performing your screening in UK? How you are organizing this strategy? Is a national strategy?
Well, not quite yet. And I think I call this a catch-22, where people say, why should we screen if you don't have a drug? And then the people say, well, if there's nobody being screened, we haven't got anybody to treat, and it gets stuck in this cycle. So I think the licensing of the first drug in the USA is a really important landmark to beginning to break this cycle. We know that it's going through the regulatory authorities in the UK, and we're moderately optimistic that it will be approved for use in 2025. So that's beginning to stimulate efforts to think about screening. The simplest form of screening is in fact the relatives of people with type 1 diabetes, because they're sitting in the clinic or outside the clinic. They're waiting with the patient. So we can find those people very easily. And actually we forget about that because those people are accessible and they're close to endocrinologists who actually know about this disease. But unfortunately, they only represent 10% of the whole population that's going to develop type 1 diabetes. Most people who develop the disease have no family history, so we wouldn't be able to guess that. So you will need population screening. But one thing I would remind people about is that we need to learn, this is very different. So I'm sure for colleagues that we're going to talk to today, for some people this is a bit of a shock, the idea that we should change this much to prevention rather than to treatment. So I think introducing many of our colleagues to this idea, many are concerned that it's dangerous, that immune therapies are going to cause more problems than benefits, and they're not used to this kind of therapy. So for me, beginning with relatives and getting endocrinologists to screen their relatives, discuss with the relatives their risk, and then begin to treat them is a really good place to start, because then people get used to it. You're right, the much harder work is screening the whole population. In the UK, we have some research schemes. We have ELSA, which is screening age 3 to 13, and it's by finger pricks. People can send in blood spots. They can do it through the internet, through schools, but it doesn't cover the whole population. We have another research scheme that has just started, which is screening adults, because it's easy to forget that 50% of new cases are adults, they're not children. So it's beginning to understand how we can do this. But behind all of this, we're beginning to understand how we can embed this into the National Health Service, into clinical treatment. And of course, screening the general population will not be done by endocrinologists. It will be done by family doctors and general practitioners. So we're trying to understand how to do that. And I will say one more thing, which is we do know quite a bit about what age to screen people. So if you screen people at the age of 12 or 13, well, 30% will already have got their diabetes. It was too late. If you screen them at birth, most of them haven't developed the antibodies yet, so it's too early. So many people believe that if you're going to screen at one time, it's probably aged around 3.5. Maybe better to screen twice. So some of these things need to be developed and embedded into the health service and routine practice.
Yeah, I think that probably society in general, general population, people need to know more about type 1 diabetes, because this is a strategy that I think that involves health system, general population, authorities, etc. I think that it is clear that it's a new period, it's a new era, as we say. Finally, we have the teplizumab, that this is something that, as I hear, is already accepted in USA for the FDA, but the EMA in Europe is analyzing. Other drugs, probably they are coming in the next years. What do you think?
Yes. I mean, one of the hardest things, Luis, as you know, in this area has been to engage the big drug companies. Yeah. And I think part of the reason...
Other partners, exactly.
Yes, other partners. And I think they've concentrated on other autoimmune diseases, on psoriasis, on inflammatory bowel disease, on rheumatoid arthritis. And we say, what about our disease? Why can you not come to us? And I would say that one of the reasons is that when they have gone to endocrinologists and they said, do you need immunotherapy? People say, no, we have insulin. And I think it's our community that needs to understand, yes, we're good with insulin, but it would be so much better if we didn't need insulin in the first place. So changing our attitudes will change the attitudes to big companies to say, okay, we'll get this to work.
Yeah, I agree completely with you, because, you know, when we are talking about these kind of drugs, that for endocrinologists, they are not common use, but oncology, rheumatoid arthritis, psoriasis, they are using this kind of drugs, and they have very good results, and they are improving the situation of our population. I think that is clearly a new period, and we are happy to having you here. Thank you for coming and waiting for listening you all your knowledge. Thank you.
It's a pleasure. Thank you.